Welcome to today's PerfectServe sponsored webinar on the coordination of care, a caregiver's perspective. My name is Eric and I'll be your operator for today's call. We have just a few announcements before we begin. Please direct your attention to your computer screen as we go briefly through how today's presentation will operate. In the middle of your browser, you will see a box containing today's slides. They will advance automatically throughout the presentation. On the bottom right-hand side of your screen, you will find a webcast help icon for technical assistance, as well as a resource list containing a PDF of today's slides and a few other helpful resources. To the right of the slides, you will also see a Q&A box to submit a question at any time. Your questions will be addressed throughout the Q&A portion at the end of the presentation. Along the left-hand side of your browser, you will see the idea wall. This is where you can give us ideas for future webcast topics. Tell us what you want to learn more about, and we will do our best to deliver. And finally, if you hear something worth tweeting about today, please reference hashtag PSWebcast in your tweet. All tweets are visible via the Twitter feed located on your screen. If you're on the phone line but are experiencing any technical difficulties accessing the web portion, please let us know by sending an email to webinars@perfectserve.net. At this time, all participants are in a listen-only mode. Please note that this conference is being recorded. At the conclusion of today's event, we ask that you complete a short survey that will appear on a separate browser window. Please disable all pop-up blockers to ensure that you receive the survey window. I will now turn the call over to Leanne Myers of PerfectServe. Leanne, you may begin.
Welcome to PerfectServe's Thought Leadership Webinar Series. I am Leanne Myers, Chief Clinical Officer at PerfectServe. In today's webinar, we are looking at our healthcare system's coordination of care through the eyes of a caregiver. We hope that her moving testimony will inspire us all to find new strategies to strengthen patient, physician, and caregiver-physician relationships. Before we turn things over to our key presenter, I do want to take just a few moments to introduce you to PerfectServe and how we help our hospitals, health systems, and practices streamline and optimize their clinical communications. Research has shown that the communication breakdown is the primary contributor to delays in treatment. This is because status quo tools and technologies often fail to address the complexity inherent in today's clinical communication processes. PerfectServe Synchrony unites physicians, nurses, and other care team members. It enables communication-driven workflows that facilitate timely care team collaboration and ultimately reduce the time to treatment. We know that many of you on the line with us today are working hard to improve communication processes, improve outcomes, reduce readmissions, and improve patient care and transitions. That is why I'm so excited to have Deborah Dokken from the Institute for Patient and Family-Centered Care with us today to share her perspective both as a patient and a caregiver. Deborah Dokken is currently a consultant to the Institute for Patient, Family, and Centered Care. Deborah's career in family advocacy grew out of her own personal experiences, including the loss of 2 infants due to prematurity and her husband's long battle with a rare abdominal cancer. As a result, Deborah became involved in programs that improve family support and enhance family participation in health care. Her very unique experiences have fueled her ambition to help bridge the gap between patients, caregivers, and their physicians to ensure others will not have the same frustrating experiences. We are very excited to have Deborah join us today and share her very personal story with us. Thank you for joining us today, Deborah, and I will turn things over to you.
Thank you, Leanne, for that introduction, and I'm honored to have been asked by PerfectServe to do this webinar today. And I'd like to just quickly outline what I hope to be able to talk about in our time together. I want to first give you a little bit of information about my own background so you know where I'm coming from. Then I want to talk a little bit about on-the-job training because that is precisely the kind of training I had as a family caregiver. I want to share a story, my mother's story, we call her Mimi, about a transition in care that had quite a few bumps in it. And then I want to share another story of care that is a much smoother one and really highlights integration. And finally, I want to end with emphasizing the importance of some key concepts, partnership, presence, and participation, and how essential they are to care and the coordination of care. And then we will save time at the end for questions and comments from all of you. As young as the age of 6, I knew that I didn't want to be a doctor or a nurse. In fact, if someone had described the path I actually have taken related to healthcare, I would have said, "No way, not me." But life happens, as we all know, and we don't always control the path that we do take. So I've had far more healthcare experiences than I'd ever imagined or wanted. In the healthcare system, I've been a patient myself, having had 4 high-risk pregnancies, 2 surgeries during those pregnancies, and extended stays in the hospital, one time for a month, another time for 2 months. As a patient, I learned what it means to feel vulnerable. I also learned that it's really hard to be your own advocate when you're actually in the hospital. I was also a parent in the healthcare system. My husband and I had 3 premature infants, only one of whom survived and is now, by the way, very healthy. We experienced extensive time in the NICU and some time in the PICU. One of our NICU stays was 6 months in duration. Truly, the NICU was home for our preemie daughter then and for us. I've also been a spouse in the healthcare system. My husband, Tom, had a rare abdominal malignancy, pseudomyxoma peritoneae, truly an orphan disease. He lived more than 20 years after his diagnosis, but during that time had multiple surgeries, participated in several clinical trials, had acute episodes like renal failure and sepsis, and really experienced a pretty relentless decline during the last 3 years of his life. Finally, I was an adult daughter in the healthcare system. My parents were relatively healthy and very independent until about the age of 80. And then, because of health issues, they moved to be near family. And that was a wrenching decision for them. Many of their health conditions were not atypical for their age, but together they seemed like a lot. Together they had macular degeneration, severe hearing loss, atrial fib, spinal stenosis, severe osteoporosis, hypertension, and pulmonary hemorrhaging, to name some of them. I really can't count the number of times I've been in doctors' offices, nor the days in hospitals. And even now, when I walk into a hospital to attend a meeting, I'm almost assaulted by the sounds and smells, and the memories, of course. I could literally be blindfolded and still know that I'm in a hospital. Recently, I was interviewed for a hospital system newsletter about the role of family caregivers. During the course of the interview, I commented that family caregivers are really not given preparation for the job. And early on, I didn't know what role I was supposed to assume, but somehow I had to learn anyway, and my learning was essentially on-the-job training. In an article in Pediatric Nursing, I talked about being a parent advocate and said, months after our third and only surviving child, Jeremy, came home from the NICU, I realized that our lives had changed forever and that I wanted to do something with what I had experienced. At that point, I didn't know the term parent advocate, nor did I think of myself as one. I was simply struggling to be a good parent under unthinkable circumstances. And I should amend that quote to say, to be a good parent, a good spouse, and a good daughter. My own training broadened and deepened over the years. In the slide that you see now on the left-hand side is a photo of myself with our daughter, Abigail. And as I said, she spent 6 months in a NICU, and that was really the beginning of my very intensive on-the-job training. I hadn't ever been a parent before, let alone a parent in a NICU. Somehow, early on, I thought that it was important that I know and correctly pronounce the jargon of the NICU, because that might mean that I would be taken seriously, that my questions would be answered seriously. So literally, after spending hours in the NICU during a day, I would go home at night, stand in front of a mirror, and practice saying words like aminophylline, hoping that I would achieve saying it without hesitation because people would take me more seriously. The photo on the right is our family. My husband, Tom, our son, Jeremy, who you can tell outgrew his preeminess, and myself. The photo was taken a few months before my husband's death in the summer of 2009. You can tell in the photo from the flowering trees that it was spring. But if you look carefully, you can see that my husband is wearing a winter coat, a wool sweater, and a turtleneck, because at that time he was so frail and sick. As I said before, he lived more than 20 years after his diagnosis and was at home most of the time. But he also spent many times in the hospital. And that experience certainly upped the ante on my on-the-job training, in large part because Tom's disease was so complex and we interacted with nearly every specialty area. Often, as Tom's advocate, I could ask harder questions than he dared to as the patient. In this photo, my mother, Mimi, is in the middle, and I apologize for the grainy quality of the photo. This was taken a little more than a year before she died at age 95. I actually spent about 12 years coordinating my parents' care, and several of those years overlapped with my care of Tom. With elderly parents, I experienced new challenges as a family caregiver because it was hard to balance being the advocate and the coordinator, but still respecting the independence of my parents. So I've had lots of practice, and eventually I think I've gotten pretty good at being a family caregiver. But I've also become frustrated often in that role by being in the role with no training, and even more so by having little validation and support, but still having the responsibility of being not only an advocate, but also a coordinator of care. At this point, I've actually made a career. I'm a family advocate, a family leader, whatever terminology you might want to use. I've been involved in a number of programs and projects related to family support in healthcare. I've been on numerous committees, including at the FDA and the Institute of Medicine. And currently, I work as a consultant with the Institute for Patient and Family-Centered Care. I've also had many opportunities to speak and write, and thus reflect on my experiences. And it's that reflection that I hope to be able to share with you today in ways that will be helpful. I want to return to my mother, Mimi, as we called her, and to share a story of transition in her care. But first, just a little background about Mimi. Mimi is now buried at Arlington National Cemetery with my father. A Midwesterner, Mimi was fiercely independent, even at age 95. She did not want help from anyone other than family. After the death of her husband of more than 60 years, she lived alone for 6 years. And she refused over and over again to even talk about assisted living. Undoubtedly, that need for independence contributed to the late diagnosis of her squamous cell carcinoma. I think really Mimi believed that if she told anyone that she was sick, she might actually have to go to assisted living. But finally, she was admitted via the ED to the hospital, had surgery for a colostomy, and then received palliative radiation. During the days of radiation, she was in a hospital rehab unit. Mimi died in home hospice about 3 months after her diagnosis. And I'm going to share now the story of her transition from acute care to rehab in the same hospital. I've entitled the slide, Down the Hall to Alaska, because indeed, although Mimi's transition was literally down the hall in the same building, we might as well have put her on a medical transport and gone to another hospital in Alaska. Because in this particular transition, there was lack of communication, lack of information sharing, and indeed lack of continuity of care. And the result was pain and harm to Mimi and distrust on her part and ours in the system. Let me just share a few of the details of this transition in its first few hours. As I said, Mimi was literally transported just down a hallway and was admitted to a room. She had at that time both severe vision and hearing loss, but the clinicians in the first hour or so repeatedly stood at the foot of her bed and tried to talk to her. She couldn't hear anything they said. She had required fast-acting morphine for any movement or positional change in the acute care side, but her IV line had been pulled before her transfer. I had asked about it and was told that rehab didn't like to deal with IV lines. Consequently, Mimi screamed in pain when the admitting nurse in rehab tried to examine her. It took about 2 days before we could actually get a prescription for fentanyl lollipops and had to get them at a pharmacy outside the hospital. And finally, the rehab unit seemed completely unaware of the fact that Mimi needed to be transported each day for radiation and that she had to be transported the very next day. I know that all experiences are not like that one, but this one was real and I think highlights the need for communication and coordination. Frankly, patients and families don't know, or I believe don't even want to know, what the rules or lines of communication are among and between clinicians. They just want to experience an efficient and effective result, namely quality care for them at the moment they need it, including during transitions. But as I said, I know that not all experiences are like that one. So I want to talk about another recent experience, a story of coordinated care, and that is my own recent visit and physical with my own internist, Dr. Lee, who, by the way, is connected with the same hospital that I just talked about. Dr. Lee is a superb diagnostician and coordinator of care. And those skills were fully tested with my husband's complex disease over many years. In addition to that, Dr. Lee is frankly just a gentle soul, and he has never disappointed us. In my recent physical with him, he used 3 tools available to clinicians very effectively and in a really integrated way. The first was technology. He had, to me, this amazing handheld ultrasound about the size of my iPhone. And with it, he examined my heart, my aorta from different views, my kidneys. But the technology wasn't a barrier because Dr. Lee used it as an opportunity to interact with me. He talked about what he was seeing. And then later, we went in his office and saw the films on his computer together. Dr. Lee is masterful at using another tool, namely touch. And he did it in my recent physical. I want to share one of my favorite quotes that relates to the tool of touch. This is a quote from Abraham Verghese, and I'm sure many of you have read Cutting for Stone. In this quote, Verghese talks about the physical exam of a patient. Here the actual body becomes the text, a text that is changing and must be frequently re-examined and read. One of the things that I really appreciate about that quote is the analogy of writing, which is so apt for an author like Verghese. The third tool that Dr. Lee used in my physical was listening. And in many ways, to me, that is the one that is so important to the patient and family. And once again, I have a favorite quote to share. This one is from Rita Sharon. I'm sure many of you have read her work on narrative medicine, and this quote is taken from a beautiful essay called "Let Me Take a Listen to Your Heart." When we listen either to the murmur of the heart or to the story of an illness that a patient entrusts to us, we are obtaining something of great meaning. And obviously, the power of this quote is the double entendre about what it means to listen to the heart. I believe strongly, and I know most clinicians do, that all three of those tools are needed and contribute to the whole or integrated picture of the patient, and that together they ensure quality care, coordinated care, and trust in the relationship between clinician and patient and family. My internist, Dr. Lee, takes this integrative approach to care in my health. And very importantly, he relies heavily on what I say, the story I tell. He knows that other things happening in my life matter to my health. And he used that same approach when I was in the role of spouse and family caregiver. Over the many years of my husband's illness, I called his office and asked that he be interrupted only twice. Both times I said, "Something's really wrong with Tom." And Dr. Lee did not hesitate, but only said, "I'll call the ED and alert them. Take Tom there immediately." He trusted my instincts and my information. At that moment, we were truly partners in caring for Tom. By the way, one of those instances, Tom was in renal failure. The other, he was septic. The experiences I've had with Dr. Lee don't have to be serendipitous and individual. In fact, I believe they should be system-wide. And indeed, many hospitals and other settings of care are doing that by embracing the principles and concepts of patient and family-centered care. And in a moment, I'll talk a little bit more about patient and family-centered care. This past June, Leanne Myers in PerfectServe's blog, The Connected Clinician, wrote about the importance of putting the patient in the driver's seat in order to improve care transitions. I found this photo and thought it was perfect to bring life to that comment of Leanne's in the blog. Because I think in this photo, the driver looks not only happy, but confident and in control. He's definitely not anxious or afraid. I also want you to note that he's not alone in the front seat of the car, but clearly has someone he cares about at his side, sharing his experience. And as we all know, with driving among couples, the woman in the car is perhaps telling him how to drive or to slow down. So what does it mean to put patients and their families in the front seat of the car? To me, it's really recognizing that three words are so essential to care and coordination, and those words are partnership, presence, and participation. it's also clinicians acknowledging and utilizing the expertise of patients and their families. I was right when I told Dr. Lee something was wrong with Tom. I was able to explain to the admitting staff in the rehab unit that Mimi had had morphine before for any positional changes. These words are well described in the philosophy and core concepts of patient and family-centered care, something that has been championed by the Institute for Patient and Family-Centered Care for more than 20 years. I've seen the list of people who are participating on this webinar, and I'm sure that all of you are familiar with patient and family-centered care and its core concepts. But I'd like to just quickly review those core concepts now and add a little commentary of my own. The first concept talks about treating people with respect and dignity. And I go back to Mimi's story of transition, and I remember feeling so strongly at the time that there was no dignity for her in having people talk to you when you couldn't hear what they were saying. The second concept is about communicating and sharing unbiased information with patients and families. But I'd like to expand that and say it's sharing information and also eliciting information from patients and their families, making the communication two-way, the kind of listening that my internist, Dr. Lee, does so well when I go to see him. The third concept is about encouraging and supporting patients and their families to participate both in care and in decision-making at the level that they want to do that. To me, effective patient and family involvement, or good driving, means more than just acknowledging the importance of partnership. It also requires supporting patients and families in that role. And finally, the last core concept talks about collaboration among patients, families, and providers, not just at the level of care, but also in policy and program development and in professional education. And I, again, thank PerfectServe by involving me in professional education today. Another way of talking about patient and family-centered care is that it is working with patients and families rather than just doing something to or for them. And it's that word with that really communicates the message of partnership. I said that the Institute for Patient and Family-Centered Care had been working for more than 20 years and has many resources and services related to patient and family-centered care. And I wanted to share one set or package of publications with you today. We call it the leadership package. The primary publication is entitled Partnering with Patients, Residents, and Families. So again, coming back to highlighting the need for partnership, but also emphasizing that patient and family-centered care and partnership apply in all settings of care, whether hospitals, ambulatory care, or long-term care. The first and the larger publication in this package is designed for leaders and really builds the case for patient and family-centered care and building partnerships and how they can do it at the leadership level in organizations. One of the smaller publications, the one at the top right, entitled Essential Allies, is intended for staff liaisons who really have the job of involving patients and families within organizations in things like policy development and education. And finally, the remaining publication in the package, Words of Advice, is a wonderful little guide for patient and family advisors, people like myself who are involved in healthcare institutions. The Institute has many other resources and programs, and a little later I will show a slide with our website address on it. But I wanted to talk now about a new program at the Institute. First of all, because it strongly relates to the role of family caregivers and their importance in quality, safety, and transitions in care for patients. And secondly, because it's a program that I've been very involved in the development of. This program is called Better Together, Partnering with Families. So again, emphasizing that word, partnership. And also the need for the presence and participation of family members in patients' care. This is an international initiative of our organization that began about a year ago, and we are partnering with other organizations like the American Association of Critical Care Nurses, the American Society for Healthcare Risk Managers. We are also partnering with the Canadian Foundation for Healthcare Improvement, and in fact, the Canadian equivalent of the Better Together program will roll out this fall. So to explain what's at the essence of this program, I want to share this quote from an intensivist named Samuel Brown, who published this commentary in the British Medical Journal this past February. And Dr. Brown really kind of challenged all of us with his quote. As policymakers, clinicians, and reformers move to create patient-centered care and to engage patients and families, it's hard to imagine a better target for intervention than physical barriers to participation. We cannot coherently advocate engagement while employing clinician-centered visitation. And so Dr. Brown is really referring to what is at the heart of the Better Together campaign, and the fact that there are still hospitals that restrict times when families and other designated care partners can be with their loved ones. But as I said before, those loved ones, those patients, can't always advocate for themselves. They can't always ask questions or provide information. And indeed, we have many tragic but true stories of patients who have died alone in ICUs and other parts of hospitals because it just happened to be after 8 p.m. when visiting hours were over. Obviously, we feel very strongly that those restrictions on family presence and participation are not congruent with patient and family-centered care. And that's why the Institute has launched this campaign. I want to reiterate what we mean in this Better Together campaign by partnership. It means that patients define who their family and other partners in care are and how they will be involved, and that families and other partners in care are not only encouraged but also supported to be present and to participate in care planning, and decision-making according to the patient's preference. The goal of the Better Together campaign is to change or eliminate restrictive visiting policies in 1,000 hospitals by 2017. But in launching the campaign, we recognize that hospitals have many priorities for the time of their leaders, clinicians, and staff. So indeed, they have no time or need to reinvent the wheel, and that it is in fact better to build on the experience of others that have already done this change in policy and practice. So at the heart of this campaign is a toolkit of materials for hospitals to use and adapt. All are free and available online, and I will just quickly walk you through some of the materials in the toolkit. There are 5 sections. The first one centers on strategies for changing policy. And some of the materials there are an organizational self-assessment, profiles of other hospitals that have already done this, and sample policies and guidelines. There's a wonderful piece called Facts and Figures about family presence that really addresses some of the myths and concerns that are very real to staff members in thinking about making this change. The second section of the toolkit has a number of strategies and materials for educating staff, because we feel very strongly that must go hand in hand with changing policy. The toolkit also has small pocket guides for staff and families to think about working in partnership together. These pocket guides are built on acronyms. The staff one is partners. The family one is the acronym together. So again, partners together. The toolkit contains videos of varying lengths, tracing the experience of a public hospital in the Bay Area as they successfully changed their visiting policy. And then there are also some media resources, including a press release. To end talking to you about this Better Together campaign, I want to emphasize again that I believe to improve the care, the safety, and transitions for parents, it's imperative to partner with them and with their families. But that means more than just talking about it or paying lip service. It means actually supporting and empowering patients and their family caregivers in those roles. And on the left-hand side of this slide, you see the acronym TOGETHER from the Pocket Guide for Families in the Better Together Toolkit. And that's really what that pocket guide does. It reminds patients and families that they have expertise about themselves and about their own condition, and that that expertise needs to be shared with healthcare professionals so that indeed everyone is on the same team in the care of the patient. I'll share one last quote from the National Patient Safety Foundation's Lucian Leap Institute in 2009 in a publication called Transforming Healthcare, a Safety Imperative. Lucian Leap and his colleagues said then, families are respected as part of the care team, never visitors in every area of the hospital. And indeed, that is what we are saying in the Better Together campaign. This slide is the logo of the Institute for Patient and Family-Centered Care and our website. I hope that some of you will check out the website and see the many resources that the Institute has to offer hospitals and other healthcare organizations. I hope today that I was able to give you at least a glimpse into the perspective of a family caregiver and some thoughts about communication and coordination in healthcare systems. I know that I learned from multiple experiences, and honestly, I don't wish that on anyone else. And I also learned from on-the-job training. But now I know that it doesn't have to be quite that hard for other family caregivers. And so I do the work I do now because I hope I can help make the path a slightly smoother one for other patients and families. And I think that belief is true of most of us who are advocates or patient and family advisors, that we're really trying to make the path a better one for other patients and families. I thank you all for your time and attention, and now Leanne Myers is going to facilitate questions and comments from you.
Thank you so much, Deborah. At this time, we would like to allow for audience questions. There already are quite a few in the Q&A box, so we'll get through as many as we can in the remaining time. Deborah, the first question is, where can we get the pocket guides, and is there a cost?
One of the slides, the one that had the outline of the toolkit, the web address is at the bottom. So if you link directly to that ipfcc.org/bettertogether, you can find all the materials there, including the pocket guides. All of the materials are free to anyone who wants to use them. The pocket guides, for instance, are already in a format that can be taken directly to an in-house or a Kinko's kind of printing facility. It's all set up, ready to go, and there's even space for organizations to add their own logo.
Great, thank you. And we'll be happy to send the link out in our follow-up as well.
Okay.
Next question, Deborah, is how do we put patients and their families in the driver's seat?
Well, for me, first and foremost, I think it's acknowledging and telling patients and families that they have expertise and that you as clinicians want that information because it's important to diagnosis, to care, to safety, etc. Because frankly, as patients and families, we're not all told that, maybe infrequently told that. I remember when our daughter Abigail had to be transferred from a NICU, the NICU where she'd spent almost 6 months, to a PICU in a larger hospital. And I was beyond anxious about the transition. I was afraid that no one would know Abigail. So I typed up 4 pages of notes about my daughter: feeding, how she liked to be stimulated, etc. And I brought it with me to the new hospital. But I was also kind of worried that the staff would think that I was overstepping my bounds. So I remember kind of shyly handing it to the admitting nurse at the new hospital. But she took my notes, read them, and said, "What a wonderful care plan." And then she took my notes and put them in Abigail's chart. And I can't tell you how validated I felt there. She had used a medical term, care plan, for something that I had done, and she had made it part of the chart. And I think it is that validating the expertise of patients and families, to me, that is absolutely key.
Great, thank you. Just as a reminder, please hit F5 to post ideas to the idea widget. The next question, Deborah, for you is, as physicians, how do we balance taking care of our patients and taking care of their families' needs as well?
I've heard this question before, and I think it's a really good one, and I'm sure it's on the minds of physicians and other clinicians a lot of the time. But to me, it's really important to not think of patients and their families as either or kind of robbing Peter to pay Paul. I think because families or other care partners share the same overall goal as physicians, namely the well-being of the patient. They want the patient to be the priority. And when we're talking about needs of family members, one of their principal needs is the assurance that their loved one is getting good care, is safe, etc. So I think most family members would in no way want to detract from their loved one who's sick. But I also think it's important to remember that the key terms we've been talking about today, like partnership and team, suggest that everyone has a role that contributes. And to think about families in that way, rather than being an added burden for clinicians, families can do things, can help, can truly be members of the team. They can calm the patient. They can provide invaluable information. They can help with care and the patient's safety, like the risk of falls. And that families play a huge role in a successful transition to home. So I think it's not as much balancing the needs of patients and families, but recognizing that they are so congruent.
Yes, agreed. Deborah, what resources do you personally rely on most for additional support as a family advocate?
Well, years ago when I started, I just kind of stumbled into doing all of this. I think I shared a quote that suggested that. I started a NICU parent-to-parent support group and then joined one board and then the other. But eventually I actually met Bev Johnson, who is the CEO of the Institute for Patient and Family-Centered Care. And I was stunned to learn then there was actually a movement for the issues I'd been experiencing on my own. So I think that's one thing that's really important is as a patient family advocate to know that there are other people out there like yourself. As patient and family-centered care has gained acceptance over the years, there are now more opportunities. Many hospitals, for instance, have what are called patient and family advisory councils, and they actively recruit patients and families for those councils. I'm on such a council now for a hospital that is part of a larger healthcare system, and actually we're working on a system-wide strategy to not only recruit but to train patient and family advisors for the council and for other work groups. But there are also other opportunities. Organizations like the Institute have listservs. There are conferences and seminars that have tracks that are focused specifically on patient and family advisors. And then there are a growing number of publications and materials now, like the handbook, Words of Advice that I talked about in that 3-part package.
Great, thank you. And that was the last question that we had, and that brings us right to the top of the hour. Deborah, thank you so much for sharing your story and your presentation today, as I know this is something that everybody in healthcare is working toward. At this time, we'd like to wrap up, and if you would like any additional information on how PerfectServe can help your hospital practice or system, let us know using the poll feature located on your screen. I also wanted to share with you the next few events in our webinar series. Our next webinar is scheduled for September 24th, where we will partner up with Orange Coast Memorial Medical Center to expand upon keys to achieving successful population health management and best practice for seamless communication between clinicians in different care settings. On October 1st, we learn about Lean Six Sigma methodology from a master black belt. As always, PerfectServe Thought Leadership webinars are free, so please register by visiting PerfectServe.com and clicking on the Knowledge Center tab. Again, I would like to thank Deborah and the Institute for Patient and Family-Centered Care for an amazing presentation today and helping to share the story with us. And also, thank you to our audience for joining us. Please take a moment to complete our short survey and tell us how we did. Everyone have a great afternoon. Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may